Hey guys, and welcome. This is the first video in the EKG series. This video is designed to cover fundamental concepts of EKG interpretation. Now, before we begin, a quick intro. We should talk about what this video is. And this video is a introduction into pattern recognition for interpreting 12 lead. Okay? What this video is not, and what this video series are not, is it is not strictly a STEMI recognition video series. There are many more things that occur on 12 leads that we need to be aware of besides STEMIs. Okay? Furthermore, it's not a basic interpretation video. And that's to say, there should be a solid understanding of millivolts and milliseconds and how many squares those are, and how to determine if something is a sinus rhythm or a junctional rhythm, things associated with ACLS. Right? Those skills you should be relatively comfortable prior to coming into this video series. Right? And real quick, the motivation for making this video is that I think that people struggle with 12 leads, not necessarily because they can't do it, but because the education of 12 leads seems to be a little flawed. So I've come up with this EKG pyramid that I think helps recognize the steps that someone goes through when trying to understand 12 lead and get more comfortable with 12 lead recognition. And that bottom step is that basic interpretation skills that these videos are not really designed for. And again, those are is this a sinus rhythm? Is this a junctional rhythm? How many millivolts elevation is present? Okay. The second tier, once we have a good understanding of what those squiggles mean, well, there are some steps that we have to take to translate that into EKGs. Components of EKGs, right? We have to go from, well, let's just look at lead 2 to now we're looking at 1, 2, 3, 4, 8, so on and so forth. There's not a fourth lead, hopefully, right? And then once we're comfortable with the components of an EKG, well, when we start looking at patients, we start noticing that not everyone has a textbook EKG, but that doesn't necessarily mean that they are sick. So the second step we have to figure out is, well, what is a normal variant, to the best that we can figure out, versus when is something that's different about this 12 lead become a pathological finding? When does it become something that we're concerned about? And once we can start weeding through what's a normal variant versus what's a pathological finding, then we can start associating those into patterns. And we can start saying, well, I know that this type of pattern is associated with ischemia versus, this type of pattern is associated with some conduction issues. And that can help us triage and treat our patients accordingly. Now, the last step of this pyramid is what I call the analysis stage. Right. Now, the analysis stage is not within the scope of this video series because this relies very heavily on both the physiology and the pathophysiology of cardiac muscle and the electrophysiology associated with 12 leads, and this video isn't designed to go over or review those topics. So we're going to find that the first video in this series, this one, we're going to go over the components of a 12 lead. So what are those, that bridge or that gap that we have to cross from going from a basic interpretation to now we're looking at an EKG. The second video of this series is going to talk about how we can start differentiating normal variants versus pathological findings. And then the final third video of this series is going to go over pattern recognitions for specific disease states. Okay. And as a motivating example, if I were to hand you this 12 lead and I would ask you if everything is okay on this 12 lead, what would you tell me? And the beauty is, from just this episode, and when we finish, we're going to review this 12 lead, and we're going to see that after we have a good understanding of what should a 12 lead look like, we can very quickly start weeding our 12 leads into two piles. Okay. So there's no time like the present. So let's go ahead and get started. So, alright. So the first part of this video is we're just going to be re-examining the parts of the wave. We're going to be looking at each part of the QRS complex to really get a firm understanding of what each part is. And so the first one, as usual, is the P wave. There are some things we should remember about the P wave. We should remember that this is the first deflection noted in a complex. And notice that this could be either a positive deflection or a negative deflection. Typically it is less than 120 milliseconds wide. Let me go here. It should be less than 120 milliseconds. And it's typically symmetric. Although we'll see later on that that's not strictly true. The second thing we want to look at is the Q wave. And now the Q wave is a little subjective. The Q wave is any negative deflection that proceeds in R wave. So that almost implies that without an R wave, you cannot have a Q wave. And if we go over here to our example, we see here is our P wave. Here's our R wave, that positive deflection. And so since we have this negative deflection right here, that becomes the Q wave. And this may be a good time to review what I mean by positive deflection or negative deflection. We'll see, so let's go to the example above. We see here that we have this nice straight line, which we call that baseline, or any wave that dips below the baseline is considered a negative deflection. Any wave that comes above the baseline is considered a positive deflection. So again, when we go back over to the P, Q, and R, we see that that Q wave is negative because it falls below the baseline. And we see that R wave is positive because it comes above that baseline. And so if we go through the example again, we see here we have in lead 3, we have a little P wave. We have a negative deflection preceding a positive deflection, which makes that negative deflection our Q wave. Interestingly, if we go up to AVL, we notice a P wave. We notice that positive deflection, that R wave. But since there's no deflection below the baseline, there's no Q wave. And so that's a good thing to keep in mind. The next wave we are concerned with is that R wave. And we reviewed it just now, but for the sake of completion, the R wave is the first positive deflection after the P wave. So again, if we look at this example, we have our P wave. We move to the right and we see the first thing we see is this negative deflection. That's our Q wave. But then we see this positive deflection, which is our R wave. And if we come to the next complex in lead 2, we say the P, we see another Q, and we see another R. If we move over to AVL, we see a P and an R. Remember, we said there were no Q wave because there's nothing dipping below that baseline. Correction, there's nothing dipping below the baseline before the R wave. The S wave. The S wave is any negative deflection between the R wave and the T wave. So if we look at this example, we have this P wave present. We have the positive deflection, which is our R wave. And then here's our T wave, although it may look a little strange to us right now. And we see that we have this negative deflection in between that R and the T wave, making this the S wave. Very cool. The J point, one of the more important things to recognize on a 12 lead. And the J point is defined as the isoelectric point between the S wave and the T wave. Now, what do I mean by isoelectric? Let's look at this. So isoelectric. And basically that just means it's flat, right? So if we come over here to the examples, we have our P wave, we have the R wave, and right before the R wave we have this tiny negative deflection, which tells us we have a Q wave. And after the R wave and before the T wave, we have this tiny little negative deflection, which is our S wave. And we see as that S wave proceeds up, at some point it becomes flat. And that flatness is isoelectric, which makes it our J point. We see even further in example B that we again have a P wave. We have that positive deflection making that our R wave. Before the R wave we do have this negative deflection, which is our Q wave. But we'll notice that after the R wave and before the T wave, nothing goes below the isoelectric point, so there's no S wave. But we know where the S wave should be. We know it would be here if it was there. And so as the S wave comes up and that flatness occurs, that's the J point. And you can go through the other examples C and D. But E is worth pointing out that preceding the J point, that flatness, this small hump is referred to as the J wave. Another important component of the QRS complex is the ST segment. Now the ST segment is the segment between the S wave and the T wave. But an important note is that the height of the T wave is measured at the J point. All right. So if we look at our example here, we have that P wave. We have that tall positive deflection, which makes it our R wave. We have that T wave, and before the R and the T wave, we have that negative deflection below the baseline, so we have that S wave. And we see as that S wave proceeds up, we get flat right here, which makes that our J point. So if we were to measure the ST segment elevation on this, we would go from the baseline up to the J point. But keep in mind, the entire ST segment itself is this part right here. Remember, since the S wave is a negative deflection, you can quickly tell when the S wave ends by looking at the baseline. Lastly, but not least, is the T wave, which is any deflection subsequent to the QRS complex. I don't think I spelled that right. Okay. And here we have that P wave. We have that dominant R wave. And after the QRS complex, but in this case it's just the R wave, we have this deflection, which is the T wave. Now the question becomes, as we may have noticed in our previous examples, are all the waves the same throughout? So for instance, we just had one that was just an R wave. We had one that was an RS wave. And the question is this normal? And we're going to see that that is in fact normal. And we're going to talk about how we can identify different QRS complexes and how they look and how we can describe them and talk about them. And that's what's going to happen now. And so the question we have now is each QRS complex the same? And it turns out that it's not. So let's have a quick look. Notice that in some of the complexes, such as in this box, we only have a positive deflection above the baseline. Well, we remember from our definition that a positive deflection is an R wave. So in some complexes, you only have an R wave. Furthermore, in some complexes, you might have a little bit of an R wave, positive deflection, followed by that negative deflection, so you would have an RS complex. Now, one of the things to note as we work through this is that there is a way to notate which part of the wave is larger or smaller. And so let's have a look at these two examples. We notice that in the instances where the R wave is bigger and the S wave is small, we denote that with a capital R and a lowercase s. Versus if the R wave is smaller than the S wave, we do the opposite. We put in lowercase R wave and a capital S wave. This practice is extended even further into the last example, where we have a little Q wave, a big R wave, and a little S wave. So we put lowercase q, capital R, lowercase s. When they're the same, we put them both as capital. So when the Q wave is the same height as the R wave, we have a QR complex, and they are both capitalized. One negative deflection from the baseline is considered a QS wave. So we'll note that there's no just a Q wave and no just an S wave. Another thing to note is, what's the difference between this and this? They both have a positive followed by negative, followed by another positive deflections. But why is this one an RSR prime complex and this one is just a RR prime complex? And a keen eye would note that, well, that's because in this complex, that little tiny wave dips below the baseline, which officially makes it an S wave. It's a negative deflection. Whereas in box number 2, we see that although there is still that negative dip down, it never crosses the baseline, so it never becomes an S wave. Sometimes, let me get rid of this. Sometimes we'll see that little notching occurs, and we just say art notching. There's nothing too fancy going on there. The difference between notching and an RR prime is a little subjective. And sometimes we'll see these complexes that are pretty messy. Right? And we call those fragmented. And so now we have the tools to recognize when different QRS complexes may or may not have all of the components of a QRS complex. Some may just be an R, some may be an RS, some may be a QR, QS, so on and so forth. So if we were to go through this example, we would see that lead 1, what type of complex is that? We would see that that's an R complex. How about lead 2? We would see lead 2 is also an R complex. What about lead 3? We would see that lead 3 is an RS complex. Right? We see that little S wave poking out below the baseline. And again, we remember that S is lowercase because it's much smaller than the R wave. How about AVR? That would be that QS. That's very hard to see, isn't it? QS complex. How about AVL? What do we have here? It looks like the QR complex, and they look to be about the same height. So they would both be capital. How about AVF? Yeah, how about another RS complex, right? We see that little bit of negative deflection at the tail end of that R wave. How about V1? V1 looks like an RS complex. Again, with that lowercase r, capital S. V2 looks the same, so RS. Now V3 they look about equal size, so this would become an RS complex. V4, the R wave is much larger than the S wave now, so we have an RS. V5, that looks like just an R wave. And V6 looks like just an R wave as well. Now this raises another question though. We have all these different leads and we have all these different QRS complexes. So the question becomes, is this normal? Right? Is this normal to have different QRS complexes per each lead? Right? So is this normal? And what we're about to find out is yes. So not only do we need to know the components of the QRS complex or QRS complexes, we also need to know where it's normal to find them. And that is what we are going to investigate next. And so now we're going to investigate how each different lead in a 12 lead looks different, but they're all telling us the same story. So in lead 1, we see that it's typically all positive. And what I mean by that is the P wave is positive. It's a positive deflection above the baseline. The QRS complex is positive, net positive above the baseline. And the T wave is positive above that baseline again. We'll see that in some instances, a small Q wave is present. But remember, because that QRS complex is net positive, the Q wave is usually never bigger than that R complex. And sometimes you might even see a small S wave. So if we look at this example over here, we see that our P wave is positive. Our QRS complex is a RS, which is predominantly positive. And our T wave is positive. In lead 2, we see a very similar story. So typically positive as well. So we have that positive P wave. We have the QRS complex is positive. You may have some small Q waves. Typically you won't have an S wave. And you'll have a positive T wave. So if we look at the example, we see that P wave is positive. We have a small Q wave. We have a dominant R wave, which gives us that QR complex. And we see that the T wave is positive as well. Lead 3 is a little bit more variation than leads 1 and 2. It's typically positive, but may have a negative QRS component. The P wave is typically positive. Small Q waves are pretty common. And the T wave is positive. So in this complex, we have that positive P wave. We have this tiny Q wave, dominant R wave, which gives us again that QR complex. And we have a positive T wave. But again, it's not terribly uncommon to, instead of a QR complex, sometimes we see a QS complex in lead 3. Lead AVR. It's definitely different than what we've seen so far. And in fact, that kind of makes it easy to remember. For it's the lead in which everything is kind of opposite. In fact, that R in augmented view right can also mean reversed. And that's because the P wave is negative. You typically have a QS complex, which is negative deflection. And that T wave is inverted. So that means inverted T. If you do have an R wave, it's small. Okay. And so here we have that negative P wave, or that inverted P wave. We have that QS complex, which is negative deflection. And we see here that we have that inverted T wave. AVL, predominantly negative. QRS complex, that is. But it may be isoelectric. And isoelectric in this case means equal parts up as equal parts down. So the R wave and the S wave, or the Q wave and the R wave, are at equal heights. P wave inversion is the most common. That RS complex is most common, and T wave inversions are most common. So here we see, a little difficult to see, but we have that inverted P wave. This R, since the R wave is smaller, we need RS complex. And we see that that T wave is inverted as well. We're now getting to the precordial leads. So V1 through V6 are the precordial. And some characteristics about V1 is that the P wave is biphasic. And what we mean by biphasic is if we have this baseline, our P wave goes up and then it comes down. So it goes both above and below the isoelectric line. Typically in V1 you will have a very small R wave. Sometimes it's not even there. You will have a dominant S wave. You have a upright T wave. And it should be noted that in the event that you do have an R wave, so if R is present, you should still not have a Q wave. So here we see in that example, we have this upright, slightly biphasic P wave. We have our R wave. We have the S wave. And the S wave is much larger than the R wave, so we call that the RS complex. And we see this small bump is the T wave. Lead 2, very similar to lead 1, but the P wave now is usually predominantly positive. The R wave is small but larger than in V1. The S wave is dominant but smaller than V1. And our T wave should be positive. And again, there really shouldn't be any Q waves. So if we look at our example here, we have that positive P wave. We have an R wave and no Q wave. We have a dominant S wave, which gives us that RS complex again. And we have that T wave. V3. V3 should be positive P wave. It should be isoelectric. That is that R should equal the S wave for an RS complex. There really again shouldn't be any Q waves. And our T wave should be positive. So again, here we see we got that P wave. We see that the R wave and the S wave are approaching isoelectricity. So we have an RS complex. And here we see we got a positive T wave. in lead 4, we should again have a positive P wave. And this time we should have a dominant R wave and a smaller S wave. This one can also be isoelectric. So the R and the S can be the same height or same length. We really shouldn't have any Q waves again. And we should have a positive T wave. So again, if we look at that example, we have the P wave, we have this R wave, this S wave, and since this time the R is bigger than the S, we say we have an RS complex. And here we see that that T wave is positive. By the time we get to V5, the pattern for the P wave should be pretty instilled, so we should have a positive P wave. V5 should have some small Q waves. It should have a dominant R wave. If there's an S wave, it should be very small. And our T wave should be positive. So here we see that positive P wave. We see that tiny Q, dominant R, which gives us that QR complex. And we should have a positive T wave. V6 should be unsurprising that that P wave should be positive. Just like in V5, the small Q wave should be there. There should be a resoundingly dominant R wave, no S wave, and a positive T wave. So looking at the example, we see we have that P wave, tiny Q wave, dominant R wave, positive T. So wow, that's a lot of info. It almost seems like for every complex, and there's 12, we have to know each one of the bits and pieces about what each one of these 12 things should look like. Now thankfully though, since this is a pattern recognition video, there is a little bit of a pattern that we can start to discern in all of these rules. So there's a 5-step pattern recognition to just figuring out at a quick glance if there's anything going on with your 12 lead. And if we remember, on leads 1, 2, and 3 all had something in common. What was that? It was that the right side of the 12 lead, right, so leads 1 through 3 should be all positive. Now again, this excludes lead 3, which can be a QS complex. But for the most part, when you look at the left side, if I learn my left from my right, everything should be pointing up. The P wave should be positive, the QRS complex should be predominantly positive, and the T wave should be positive. The second pattern we saw was that AVR should be all negative. And along with AVR and AVL were the only leads with a negative P and an inverted T wave. So if we see an inverted P wave outside of V1, where it might be a little biphasic, or we see inverted T waves anywhere other than AVR and AVL, we know that we need to investigate a little further. The other pattern was that when we were going from leads V1 to V6, we saw that the S wave got smaller and the R wave got bigger. as we wrapped around the heart. So V1 starts out predominantly negative, and by the time we get to V6, you should be predominantly positive. So if you look at a 12 lead and V1 is positive or V6 is negative, you automatically already know that something's going on. And the fifth pattern is that we really didn't see any big Q waves. So there's no big Q waves anywhere. So if you look at a 12 lead and you see big Q waves, maybe in like the inferior leads, again, you know you need to do a little bit more investigating. So if we take this pattern and we apply it to our motivational 12 lead, what do we see? So remember we said that pattern 1 was that everything on the left side should be positive, but we see that our P wave is inverted. We have an RS complex, which is predominantly negative, and our T waves are inverted. Again, we have an inverted P wave, we have a predominantly negative QRS complex, and we have inverted T waves in lead 2. Now in lead 3, we see that our QRS complexes are predominantly negative. We said that was reasonable. Lead 3 isn't as stingy as leads 1 and 2, but the P wave is still negative, and that T wave is still inverted. So our pattern 1 is something's wrong. The second pattern of AVR being negative, we see that, well, that's terribly wrong as well. We have a positive P wave, we have a QR complex, which is predominantly positive, and we have this T wave that's positive. So our second pattern of AVR being predominantly negative, there seems to be something wrong here as well. The third pattern, that AVR and AVL are the only ones with negative P's and negative T waves, we see that by virtue of AVR not having a negative P wave and not having a negative T wave, AVL has positive T waves, but it does have a negative P wave. So something's wrong again. Now that fourth pattern of looking at V1 through V6 and seeing if it wraps around the heart is a little bit harder to discern. It's obviously because we don't have V1 through V6. So we can't really tell. That fifth pattern of no big Q waves anywhere. Well, we see here in lead 3 that we have a little bit of a Q wave, and in fact it's bigger than the R wave, so we have a QR complex. So there might be something wrong there as well. And so the beauty of just taking our time and going through both each component of the PQRST complexes, as well as going through each lead associated in the 12 lead, can pay off great dividends, because we can quickly look at a 12 lead and we know that there is something wrong with this 12 lead. Now, we may not know what's wrong with it. That may take more investigating. But we definitely know that something is wrong and that we should and have to look more in depth with this 12 lead. And then so in our next video, we're going to look at that. We're going to say, all right, well, now that we've recognized that something is a little off, is it a normal variant, or is it bad enough and it's a drastic enough change that we might consider it a pathological finding? And so that's what the next video will be about. All right. But thank you for watching. I hope you guys learned some stuff. Please feel free to leave some comments, questions, concerns, snide remarks. And I look forward to seeing you guys in the next video. Thank you.